Thank you, Neil. Yes, it's been an interesting year, hasn't it? We were just talking about how many waves we reckon we have, and I think from our perspective, we think we've had 2.5 waves of pandemic, but we're definitely now coming out of the second wave of coronavirus infection. Um, as you said, Neil, we've been involved from the start or before the start. I remember in January, Pathways officers are actually, we borrow office space from University College Hospital and sit on a floor with a team of infectious disease experts. So back in January, we were hearing discussion initially of a new virus emerging. I guess our real story in relation to coronavirus and the epidemic starts partly, in fact, with you, Neil, and our conference almost this time last year. So by the time we were running our 8th International Homeless and Inclusion Health Symposium last spring, planned for March. And as the event became closer, the evidence around the huge risk that coronavirus was going to impose was rising rapidly up the agenda. Fortunately, one of my trustees is Professor Andrew Hayward from UCL, who's a member of NerveTag, and we were able the week before our conference last year to check with Andrew to say, do we go ahead bringing 350 health people together in the London hotel? He said, yes, there probably won't be an infection in the room this week, but next week we would have to cancel it. So we went ahead. And in fact, Neil, you remember we turned over the closing plenary session to focus on coronavirus because it was coming. And by that point, Andrew had produced a presentation of the best available evidence from China, largely about what the virus was doing and its infectivity, its attack rate, the mortality to expect. And Al Story, who leads the London Find and Treat Mobile Tuberculosis Service, presented a plan which we'd crafted that weekend, or he'd largely crafted, which was test, triage, cohort care. And that was presented at our conference on that day. And I'll come back to some of the lessons about actually having that event and having a network in the room on that day, which I think played a huge role in enabling that plan to land and to move incredibly fast. I think, Neil, you managed to get those videos online the following day. And I think they were viewed very extensively, very rapidly. And it helped us as a charity and other partners make the case. The epidemiology was so frightening, bluntly. The level of death expected was so severe. It allowed us very rapidly to get into discussions, and I suppose to scare the hell out of colleagues, particularly in MHCLG, who were slightly wondering what to do and what it meant, I think. So we moved very fast. And I recall by the following Friday being in a meeting with the Greater London Authority, again with, I think we were on version 4 of the plan by then. And I think that following week, everyone in was announced. And it felt like a kind of a snowball had suddenly rolled. Plainly, there were other people having influence from the housing direction at the same time. So what we suddenly saw was, yes, the national lockdown ordered. A very easy argument to make in a way that if the government is ordering people to stay at home, plainly the government must surely do something for people who have no home. Otherwise, it's effectively, presumably, putting them in an unlawful position. And that argument was won pretty rapidly. I think Louise Casey did play a real role there in getting the money, bluntly, and giving the Secretary of State some confidence to say that he could do it. And then we saw the everyone in order issued to local government. And we had the experience of yes, lots of my NHS colleagues, and we work with specialist homeless hospital teams. We help to promote and create specialist teams in the NHS. Suddenly, an incredible upsurge of mobilization of colleagues across all sectors, rushing around to try and do the best that we could across this amazing endeavour, moving at real pace with the GLA in London, procuring hotel rooms hand over fist, and procuring colleagues from the third sector to stand up staffing teams overnight, as it were, St Mungo's, SHP, colleagues from Riverside, just being asked almost over the weekend to, can you bring another group of people to staff this next Travelodge with another 100 people in it. I remember one of my nursing colleagues being in a hotel just east of the city. Actually, I think she worked 70 days straight through the first wave and on phoning me to say, I've got one thermometer, Alex, and I've got 120 people in this hotel. Can you help? So we also experienced some grave dysfunction in the sense of the health service's ability to mobilize, because she was stepping way outside her standard operating procedures and was in a hotel. She wasn't supposed to be there, but yet there she was, supporting the local third sector provider to make that a safer place. So an amazing mobilization suddenly. In London, we were fortunate to get Médecins Sans Frontières to mobilize a nursing team to staff up and open very rapidly a specialist COVID hotel. So we were able, the plan was that the street team supported by medical staff were going to cohort and identify anyone who was thought to be infected or showing symptoms, would move to a COVID hotel to keep the infection away from everybody else. And within the other hotels, some efforts to try and cohort the populations to keep more clinically vulnerable people together and less clinically vulnerable people together, a standard way to respond to an infectious disease. So absolutely astonishing. I was just saying beforehand, Neil, we now see the data that in wave one, very, very low levels of infection in the end in the homeless population in London and nationally. This really worked, giving people their own self-contained accommodation without barriers, without assessment, without question. So no thresholds applied, was incredibly helpful, incredibly in terms of avoiding disease and coronavirus infection. But actually what we also saw was incredible engagement with services in people who had often never engaged before. So we saw a real shift. We think this is to do with almost the psychology of what was offered, that it was without strings. In a way, it was a bit like a rapid, huge field-scale trial of housing first. So there was no threshold. Everybody could come in. That was the name on the tin. And then we were going to work with you. And we were going to try and mobilize whatever was needed. So in London, again, SLAM were rapidly mobilized a citywide substance misuse first-tier referral service, which had never been done before. Again, was set up in like 5 days, proving that procurement doesn't necessarily have to be in charge, and proving that commissioning, for a period within the NHS, it certainly felt that commissioners had nothing to do, which some of my clinical colleagues sometimes wonder what role they have ever. Of course, the money has to be managed, but suddenly things were happening because they seemed like the right or the safe thing to do. And decisions were escalated through the government's kind of gold command systems. Decisions were made very rapidly and things moved fast. Not everywhere, and not everything was perfect. Looking across the country, we were aware that plan that we'd launched at the conference was being used elsewhere. We had the strange experience as a charity of, quite enjoyed this at one point, there was a letter to local governments from CLG, which actually referenced the plan on our website, because we'd never actually, although throughout this we were lobbying the government to adopt that health-led plan, they never actually did. So they were referencing it back to us, which was fine, but always slightly odd that it was never, in the end, formally adopted by government. What we see now, I'm afraid, in the second wave, particularly in London, is that infections have happened very significantly in the homeless population, particularly in the hostel sector, because although the government says everyone in has been continued, the volume of accommodation is simply not there. So projects have become more overcrowded, and it turns out that particularly the new variant of COVID is actually quite infectious. It's an airborne virus, and if you have people in crowded buildings, they will spread the virus. And that's what we're seeing, because at the same time, there are some hotels still operating in London and less crowded projects where we're seeing virtually no or no infections. So we've proved what is the case. For those of us who've been working in homelessness for a long time and looking at the interactions between human health and multiple exclusion at homelessness, this is not a new phenomenon. This is what infectious disease agents do. They find their niche, and usually in our populations, they find their niche amongst poor people. Tuberculosis would be a case in point. It's interesting that which again we observe routinely, that states seem to mobilize when a disease is a threat to everybody, But when it's just a threat to our population, that seems to be not so much of a problem. And again, the issue of tuberculosis has remained unresolved in the London homeless population for 20 years, really. And we've never been able to get the degree of attention on it that we could suddenly get to coronavirus, because tuberculosis tends to remain a disease of extreme poverty, and we are, as a society, seem quite happy with that. So there's a snapshot of the year of coronavirus from our perspective. Some reflections on what we've learned about why. I mean, some things didn't go so well, but broadly, we would certainly say that wave one mobilization was absolutely astonishing in terms of, as Neil said, more or less eliminating a street population in London, not completely, but more or less, and doing it in a week or two. Again, we found that there were far more people coming into the hotels than were identified in the street count, and that seemed to indicate, as many of us thought, that there were far more intensely vulnerably housed people hidden in our society than are identified routinely in the regular ways local government collect the figures. But the endeavour was a great success, I think, at that point, and showed that we can change things very, very rapidly under pressure, and that these impediments to action, particularly the more bureaucratic ones, do seem to be impediments to action. So some other kind of more stepped back reflections on that. What I wonder whether John would agree with this, but we saw the barriers between health, housing, and social care really come down. We saw incredibly high collaboration, high trust between local government in particular and its third sector partners. We saw, from our perspective, NHS people suddenly, we come from an NHS perspective, if you like, suddenly connecting in ways that they never had before with both the third sector and housing, and being present and engaged and collaborating, finding what new ways to do things. We saw incredible innovation. That SLAM project I mentioned was just one example, but all sorts of things have happened very rapidly. A huge shift, and we've done some work on this in primary care. Total triage, digital by default, was being rolled out almost instantly into primary care. We did some work partly to express our concerns as to what that would mean for homeless patients and other patients, for example, without a smartphone or technology. But also, some of our patients, we know, really, really like those kind of interactions. So beginning to see those wholesale changes, which have been discussed for 10 years, suddenly happen in a matter of weeks. Absolutely amazing. I think one of the things we were thinking about why this change was possible at the practical level, that mobilization, certainly from our NHS perspective, maybe I would say this, wouldn't I? But we think that 10 years of work forming really a sector which didn't exist before, an inclusion health sector within the NHS. So our Faculty for Homeless Inclusion Health now has 1,600 people on our mailing list. As I said, 350 of them coming to a conference last March. Launching a plan, we had an infrastructure, we had a set of people in many towns and cities across the UK who knew their local CCG chair, who knew their local authority, and were able to say, guys, we're the inclusion health people, we have a plan, a well-evidenced, robust, epidemiologically sound plan, and we can bring it to you in Brighton or in Bristol or in Leeds or in Manchester. And we have some network capacity into the NHS, so we can mobilize the testing, we can mobilize the PPE. And that infrastructure, the prior existence of our network, we think has really, really helped mobilize a much better response than we would have seen without that. I think we've also seen, and we've seen that in the scientific world, the incredible pace at which people are producing preprints and scientific reviews. And that's been hugely powerful for us. And within our own sector, my fabulous colleagues at UCL have been putting out data very rapidly from the testing, from the epidemiology, but also from mental health. We've seen early papers about that positive impact of the hotels, for example, but quite robust science emerging very quickly. We also found in the first wave that at that point, government was listening to the science, and we could get conversations happening rapidly around the fact that we were dealing with a very dangerous new virus, and that was leading to real mobilization. And the last thing I would mention was something about motivation. There was something almost a statement of the obvious, but the arrival of a very dangerous new virus, particularly in the world of healthcare, was a huge motivator for people to act. People were very scared. People very, very worried about their patients. We were very, very worried about the extreme risk that so many people experiencing homelessness face because of their deteriorated health, because of their compromised health status, and their high risk they faced of disease and death. And that was a real motivator for change. And we saw astonishing collaborative behaviors come. Saw some people bumping into each other because they were so motivated. And we had some interesting episodes of people pitching up with really quite unhelpful stuff, but they were trying to help, which was fine, but sometimes a distraction. But that motivation within the staff teams to really go fast, which was the case within the hospital sector and other bits of the NHS too. Amazing kind of endeavour, I think, was felt, I would say, across the homeless sector into the third sector as well. Of course, that kind of volition is hard to maintain, isn't it? And it begins over time to become harder. And I think that's perhaps wave 2 has become much more challenging in all kinds of ways. But that first flush of enthusiasm. Sorry, that's what happens on. That first flush of enthusiasm was just lost. Well, not entirely lost, but it's hard for people to keep going at that degree. As I said, one of my nurses worked 70 days straight in the first wave without a break, and actually had coronavirus during that period, but kept going. And now I think, well, people in the NHS are tired. The next wave has been very brutal. We've still managed to keep a lot of things going, and it's not been a disaster, but I think that motivation is not there so much. And looking to the future, we've not seen such clarity of simple leadership from the government in wave 2. The messages have got a bit more, I think they would say nuanced or targeted, but a little less clear perhaps. We've seen less money, and as we look into the future now, the vaccines, again, interesting. I mean, there's a lot of stuff happening, and the vaccines are mobilizing well, which is good. I hear rumors amongst some homeless people now saying we think they just want to vaccinate us so they can shut the hotels and chuck us back out on the street. Back to that TB. So now we can just be homeless again because they've got a fix for this disease. And of course, we're rather against that position. I'm beginning to try and make some noise in that space. We have our conference next week, which Nia is kindly helping us with, and we'll be putting some of those points to the Junior Housing Minister in the week after next. So I thought I'd stop there, though. That's my quick canter through the last 12 months, I suppose.
Okay, Alex, thanks very much.